Hello everybody and welcome to the Community of Practice webinar. Today Alison Davis is kindly joining us as the Integration Programme Director for Health and Social Care. Alison's working on behalf of Kent County Council and South Kent Coast and Thanet CCGs, and will be talking to us about commissioning integrated models of care, specifically around creating an integrated health and social care system in South Kent Coast.
As Julie said, I'm Alison Davis. I'm the Integration Programme Director for South Kent Coast and for Thanet actually, but I'm a joint post between Kent County Council and the two CCGs that I've just mentioned in East Kent. I'm going to talk about our vision for 2020 health and care in South Kent Coast and how we are getting there. Okay, I'm going to put the programme into a bit of Kent-wide context first, explain the programme and the model of care and where we've got to, and talk a little bit about the new commissioning models and touch on contracting and evaluation. So I don't know who's out there who knows Kent, but it is quite a complex system. We've got a 1.5 million population, and that's predicted to grow by 8.4% over the next 7 years. That represents an extra 123,000 people. So the biggest increases are expected to be in the older age groups, and I'm sure that's the same with most areas. And transformation of health and social care system is a key priority to ensure that we've got a sustainable health and social care economy. Now, Kent's got a two-tier council system which adds to the complexity. So that comprises of Kent County Council and 12 local authority district councils. You can see at the top of that slide Medway, at the top of that picture. That's actually not part of Kent. Medway has a unitary authority, and Medway CCG and Medway Council are coterminous. So Kent itself has 7 CCGs. We've got 4 acute trusts that spread over 7 hospital sites. We've got 1 county-wide community healthcare trust. Actually, we've now got another one because North Kent have went out to tender for their community services and somebody else got that contract. We've got 1 mental health and social care partnership trust, and we've got many third sector and voluntary organisations, including 4 hospitals. So it is quite a complex county. So if we come down a bit micro in this, I'm looking now at the 4 CCGs in East Kent, because in East Kent we've got 4 CCGs that are all autonomous as a CCG, but we work very closely together on the transformation agenda, because our health and social care services are absolutely interlinked across the patch. So we've all got separate change programmes with similar components in the models. It's just how we're getting there that's different. So as I said, we're working together on this, and we have an East Kent strategy board which includes providers and commissioners for health and adult social care, and the board ensures that our approach is properly joined up. So within the East Kent patch, we've got 1 acute trust with 3 sites and a number of community hospital facilities. There are varying demographics, with some of the poorest people in the country living in parts of Thanet. Where we're placed brings its own problems, particularly with workforce and recruitment. We've got C on 3 sides. Mind you, it brings opportunities on the other hand. Our relationship with Europe, so we've just started commissioning orthopaedics from the 2K and Calais providers. So there are 2 sides to that coin. NHS Canterbury and Coastal are within East Kent, and they are in Canterbury. They are a vanguard site for the new models of care programme. As I said, I'm going to talk about the work that we're doing in South Kent Coast in developing accountable care organisation. So this is South Kent Coast. We've got 4 distinct locality areas really, well 5, but we split it into 4, so the Romney, Marsh and Hythe merge into 1 locality. And we've got a population of 200,000 with 30 member GP practices. We've got differences between like the Marsh is very sparsely populated rural area, and then we've got the coastal towns of Folkestone, Dover and Deal. We have a gap of 13 years between the most deprived and the most affluent patient, that's 13 life years, and we have the highest proportion of over 65s in Kent, and they're expected to increase by 15% over the next couple of years. Like everywhere else, we've got the case for change with our ongoing rising demand for care, insufficient funding, fragmented services. We've got unattractive clinical and practitioner roles that don't actually attract people into the area, and there are perverse incentives in the system. The current model of care that we've got lacks emphasis on well-being, and there's a lack of a clear contract between the patients, the public, the community, and the system. We think that currently we're providing suboptimal patient and carer experiences, and there's a lot of complexity within the system with too many boundaries and handoffs. I'm sure that everybody else recognises this in their locality. So basically we've got a health and care system that even in the short run is not sustainable. So we looked at, what should we do? Should we increase the size of services to deal with the rise in demand? Well, that's not a possibility. We haven't got the finances to be able to do that. Should we manage demand by rationing services? Some of that has already been done across the patch, but now we needed to intervene positively and change the service model. So we wanted to right-size the health and care capacity, intentionally working to support individuals and families and communities to stay strong, so diverting people from formal services wherever possible, through developing sustainable, local, flexible services. So the approach that we took, we started this work in September 2014. The approach that we took was that we decided not to go down the procurement route yet. What we wanted to do was work with current providers to develop the integrated provider system. And we thought that this would ensure buy-in and a shared vision of what good would look like. We felt that at that moment in time, we weren't able to specify what the care model should be, and procurement is costly and local services were good. They weren't integrated or designed or flexible enough to meet the local change in demographics, but they were good, and we didn't want to destabilise our provider services. So we wanted to build that real sense of belonging and ownership to the model, and therefore we took a frontline clinical practitioner and citizen co-design approach to design and build the vision and model from the bottom up. So a provider development approach, not a procurement, focused on ownership, engagement and co-design. So we embarked on a 12-week programme of work to establish a coordinated and robust service model for the provision of sustainable, comprehensive out-of-hospital care, really. So we held many workshops, and over 200 people were engaged in the process, and they helped to design the future of integrated care in South Kent Coast. We agreed that this would be an incremental process with an emergent model of care, and that the form of the organisation would follow the function. We wanted to design the function first, and then later down the line we would think what that organisation needed to look like. We've taken a programme management approach, and we've developed a governance structure, a programme plan. We've got enabling work streams focusing on workforce, integrated finance and commissioning, IM&T, etc. But key to the approach is that we're all in this together, and that local implementation and leadership is critical. The whole programme is underpinned with best practice, research, evaluation and learning, and I'll talk about that in a minute. I'll move on to our programme roadmap and governance. This is the programme plan. It spans up to 2020. We've already had year 2015-16, so we've already achieved quite a lot with our programme. We're still really in the design phase and moving into the build phase, but we're hoping to have an embryonic ICO in place by 27/18, certainly that focuses on adult care. So there are two strands to the programme: developing the provider model of care and provider development to deliver the model of care, and also developing the integrated commissioning system that includes CCGs, Kent County Council and local councils. You can see by the high-level programme plan that we intend to have the embryonic ICO in place by 2017. I'm going to talk about the progress that we have made in a minute. Okay, so this is the programme. It shows the whole programme to deliver the ICO in the middle, an integrated care organisation or an accountable care organisation. We've established the work streams, as I said, and you can see these on this slide. I'll pick out a couple of those work streams. So integrated IT, the aim there is to develop and implement IT as a key enabler to integrated care and to enhance patient care and outcomes. We've already done quite a lot of work in this area. We have developed an interoperability gateway, and that is rolling out across the patch. We've also implemented iPlato. Some people might know about this. This is rolling out across all practices, and it reduces lost appointments by text messaging from the practice to the patient, and it allows auto cancellation, which releases appointments as well for the practice. And it does things like support immunisation campaigns and increase vaccination uptake. So we're just rolling that out across the patch. We're increasing mobile working, and this is being piloted in general practice, and also things like virtual consultations are being piloted in care homes between GPs and patients, and we're working with the Acute Trust to expand the opportunity for outpatient consultations. We've also got an accommodation work stream, and that's looking at best use of all estate in the patch. In addition to health, social care, district councils, public health and voluntary sector working together to address poor housing that leads to poor health to improve outcomes. And they're currently developing an environmental assessment to be undertaken by a wide group of staff who visit people at home to link housing and health. You can see the two arrows. We've got a comms and engagement plan, and this supports delivery of the ICO. It's focusing on public and patient engagement as the model develops, and as well as staff engagement within the different stakeholder organisations, they're focusing on patient engagement. They're also working with the self-care working group to identify the way in which communication engagement can effectively support their work over the coming year, and evolving a proactive self-care strategy with local community champions. So they're doing quite a substantial amount of work, and we have a 3-year plan for our comms and engagement. We have research and evaluation work stream which underpins everything that we do, and I will talk about that in a minute. That's the ICO. That's our model, a graphic of our model of care, which I will elaborate on later. Okay, as I said, we've got a programme in place, and this is our governance structure. The programme of work is being driven by the CCG as commissioners together with Kent County Council. However, all provider organisations are partners in this, along with local councils. You can see from this diagram that we've established a programme board. It's called the Integrated Executive Programme Board. This has all stakeholders round the table at director level and executive level. We've also have a separate commissioning and finance group. This is a strategic group setting the agreement and direction for future integrated commissioning and finance. We've got 4 natural localities in South Kent Coast, and have established a GP-led locality delivery groups. We're just in the process of redesigning these to align them to begin to move the focus of these groups as we start to develop embryonic integrated provider groups in the localities. So those groups drive the model of delivery forward. We've also recently developed a GP locality leadership role for these localities, and that role will lead the development and delivery of the local integrated service provision and locality commissioning. I know this says Thanet, but we've got the same for South Kent Coast, and I didn't have a slide for South Kent Coast, so I nicked the Thanet slide. We developed a compact agreement between all partners and stakeholders across the system, and it describes each organisation's commitment to working together to deliver integrated health and social care. It provides a framework within which we will all work to achieve our shared purpose and our strategic goals. So our collective aim is to ensure that South Kent Coast people are supported to be well and healthy in their own homes and communities by delivering a connected system designed and delivered around local people located in 4 natural neighbourhoods. We've agreed 5 outcome areas for delivery, and they are: people will take greater responsibility for their own health, people will stay well in their own homes, wherever that home may be, people will receive timely and appropriate high quality care, people receive safe care and have a positive experience of care, and that there is better use of the South Kent Coast pound. The compact agreement isn't legal, but every single organisation has signed up to it. We've got about 16 signatories to that. That includes the voluntary sector, Kent County Council, the CCG, and provider organisations, including the Acute Trust and the Community Trust. So what will care in South Kent Coast look like in the future, in 2020? Well, we're looking to develop an accountable care organisation, as I said, that will cover the whole of South Kent Coast, but it will have these 4 distinct natural localities. So Dover, Deal, Folkestone and Hythe. There are differences between our localities, and they do have slightly different needs. So some services will be different across the patch. So the vision is for an accountable care organisation that commissions and provides. We're developing the local health and wellbeing board into an integrated commissioning board, thinking that it would have about 25% of the integrated budget. And we are shadow testing and developing the Health and Wellbeing Board, the local Health and Wellbeing Board, this year. We currently have a 2-tier system. We have a Kent Health and Wellbeing Board, and then we have the South Kent Coast Health and Wellbeing Board. And there are a lot of things that we have to work out as we move forward this year, particularly the relationship between the Kent Health and Wellbeing Board and the South Kent Health and Wellbeing Board. The priorities agreed at the Health and Wellbeing Board will inform the South Kent Coast Integrated Commissioning Plan, and localities commissioning intentions will also inform the South Kent Coast Plan, and vice versa. As I said, we've got 4 localities. You can see from the slide the differences in size and population. So Dover has a population of 57,000, and then Romney Marsh with 21,000. So there will be differences between the 4 localities. The localities will become providers of integrated out-of-hospital care. They will hold integrated commissioning budget and become locality commissioners for whatever it is that they can't provide. We're beginning to look at resourcing for this model, and we are actually already aligning current CCG commissioning staff and provider staff and KCC resource to deliver the model. There will be an integrated commissioner and provider development teams locally, and resource, as I said, is from the CCG, Kent County Council and existing community providers. So in red you can see I've begun to put where the commissioning teams and the provider teams will start to sit. So I'll move on to the model of care and what we came up with. So through the workshops we identified some key principles of integration. Care must be person-centred, local services wherever possible and appropriate. Care must be managed, so proactive care with one care plan. First contact is an important contact and no door is the wrong door. Seeing the right professional at the right time and not being passed around the system. And that we would have an organisation with a single purpose. So those principles came out of the workshops that we had. And they won't come as a surprise, but the important thing is that these were developed locally from the bottom up. And therefore this has developed ownership to the model. All our future work has been built on these principles so that stakeholders can see the thread running through the whole transformation programme. Interestingly, just after we'd done this work, the 5-year forward view came out, and essentially the model that local people and professionals had already described to us in South Kent Coast was the multi-specialty community provider model of care. This slide just gives more detail on the principles of the care model, and I just want to draw your attention to the first box entitled membership. A very clear, strong message came out of the initial workshops, and this was from patients and provider stakeholders. And that was about that this organisation, and this was about all of us, all the time. People were very keen that we developed a membership organisation made up of the public, GPs, nurses, care staff, etc. And they were keen that there would be a great sense of ownership and therefore responsibility. And that this was not necessarily about providing services, but that people would be supported to take responsibility for their own health and well-being as individuals and communities. So how do we know if we had it? So it feels like one service. To people, it feels like a cohesive, coordinated service. To care providers, it makes them feel like they work in one team regardless of who employs them. And that there'd be one budget managing resources for a whole population. So what will the end state look like? This is a graphic of what we think the end state will look like, and we are partway to achieving this. The vision is that as the patient journey begins in primary care and all or the majority of patients are registered with a GP, that is where we think the care should be coordinated by a primary care team with the aim to keep people as local as possible. The primary care team will be list-based, so care will be coordinated around a GP's practice or a group of GP practices, and the team will consist of the GP, care coordinators, domiciliary carers, nursing, care management, primary mental health, health visiting, and a number of others. The primary care team would be responsible for supporting care homes and domiciliary care providers and learning disabilities, and that would be through maximising the resource and expertise around them. So the people that work in the LD teams and the older people's nursing teams, etc. We're developing hubs in all localities which will provide both planned and unplanned care, either within the hub via a rapid access clinic, outpatients clinic, face-to-face or virtual, or minor injuries unit. We'll have integrated medical support in the community, flexing secondary care support to primary care out of hospital as far as we possibly can. We'll have safe, more specialist secondary services, ensuring hospitals would only be used for things that hospitals should be doing, so specialist and real acute care. And we're linking up the system via a shared record and shared care plan held and updated by the primary care team. The localities will be supported by a range of other services that you can see along the bottom of the slide in blue. So providers are currently organising themselves to deliver the new service model, and we have written into all contracts that this is the approach that we expect them to take. So the out-of-hospital provision will be through the Integrated Accountable Care Organisation, and we are establishing our commissioning of Total Place through the Health and Wellbeing Board and through the localities. This vision fits into the East Kent vision, and the East Kent vision is to deliver comprehensive integrated local care and health services tailored to communities and provided through 4, and we're calling them at the moment MCPs, supported by a chain of high quality, small acute hospital services with access to safe specialist services. Okay, so over the last 2 years, Kent County Council have been transforming their adult services across the whole of the county, focusing on best use of existing resources, efficiency and effectiveness, and improving outcomes for people. They've now aligned their older people services with CCG boundaries. So the transformation of social care has to continue, but KCC are now in a really good place to look at alternative commissioning and provision models that fully integrate with the NHS this year. So it's one of our key priorities for 16-17. There's a lot of work happening on the ground in terms of integration, but we need to look strategically now at what that actually means for commissioning. Our integrated model is focused on supporting and promoting independence and wellbeing and ensuring optimal health and outcomes for people, and work will be centred around the individual and not around a service. So the individual older person's journey will include care navigators, community agents, and these will signpost and build community capacity. We'll have integrated OT, in fact we have got an integrated OT service to assess and support and rehabilitate older people at the earliest opportunity, maximising their independence and reducing reliance on services. This will all work as part of the community team along with GPs, nurses and domiciliary workers. One of the areas we have to focus on is social isolation. As people get older and have more long-term conditions, their quality of life can reduce, and isolation is a big risk factor. Wellbeing is about more than medically or socially managing. We need to design our services to support people and communities to manage and feel in control. So we're developing person-centred circles of support within communities. There are hundreds of people and groups out there in communities, all providing some sort of community service. We're currently identifying all of these, and we'll develop community asset registers and local information centres and connect the community to them using the Care Navigator community agent role. They'll be linked into general practice and the primary care teams. So we're developing a form of social prescribing, promoting non-medical interventions to improve people's health and well-being. This is the model of care roadmap and high-level timeline of what we need to do operationally, with the aim of having the ICO in place by 17-18. We've got a number of priorities for next year operationally. We need to continue to fully establish the team in primary care that I described earlier, including appropriate elements of children's services. We need to make sure this is all supported by integrated IT. We need to fully implement the MIG, the gateway, to make it fully interoperable with care plans so that we can share these electronically, because at the moment we can't do that. And we need to fully implement the virtual consultations. We've got a number of other priorities, operational, but we are set to be in a position that by 17-18 we will have our embryonic accountable care organisation. I'm going to move on a little bit to integrated commissioning, because this is absolutely critical to this model, and this is the other arm. So we're developing the model of care, and we're trying to develop the integrated commissioning system as well. You'll recognise this. These are the way that care is currently commissioned at the moment. So KCC commissioned care, Public Health commissioned care, NHS England commissions, and the CCG commissions, and then outside of that, the District Council commissions. What we want to have is a co-commissioning or integrated commissioning structure in place that aims to deliver one consolidated strategy for South Kent Coast, and that will be supported by one consolidated budget. So what we're saying is, in terms of commissioning models, that the local Health and Wellbeing Board, South Kent Coast Health and Wellbeing Board, will take on responsibility for some of the commissioning. The accountable care organisation within South Kent Coast in the locality will also be responsible for commissioning integrated care. Alongside this, we're having to develop the CCG alongside the above, because currently the CCG is a statutory organisation and has statutory duties and accountabilities, as has Kent County Council. So all of this has to be worked through as we move through the next year. We're also aligning our primary and specialist commissioning to seek devolution within this new model. This is the roadmap for the Health and Wellbeing Board. This is just a one-year roadmap. Our aim is to develop the Health and Wellbeing Board into an integrated commissioning board with a flexible approach that enables the board to adapt to changing as we move forward with our transformation plans. So the intention is for the board to become the local executive decision-making body for the integrated budget. It'll have fresh powers and duties and be supported by a single commissioning function. And if you've seen the King's Fund options paper around integrated commissioning, this is one of those options. So clearly there's a significant amount of development to be done with this board, and also there would need to be a change in law for it to formally become what we want it to be. And there are many questions with this model, not least the accountability and budget spend decision-making powers, the relationship, as I said earlier, with the County Health and Wellbeing Board. All these things and more have to be thought through and designed within the current constitutional constraints of the partner organisations. We've agreed that the Local Health and Wellbeing Board will run in shadow form from this year and focus on two priorities. So they're going to focus on obesity and frail elderly. And we're designing a development programme for the year that will run alongside the shadow running of this board. We've developed a statement of intent for commissioning partners that supports the commitment of all partners to develop the board into a commissioning board. So we're developing place-based budgets as well, and integrated total place budgets. So far we've managed to split the CCG budget by practice based on practice population and profile. It includes all spend except some mental health services and spend with acute providers. We have begun to actually add to that Kent County Council spend, not all spend, but older people's spend into that out of hospital budget. So if we go to the next slide, you can see what this looks like. So this is the South Kent Coast out of hospital spend for health and social care with the exclusions that are outlined in the box to the right. We're in the process of looking at local council budgets and spend to add into this mix, but it is fairly complex. For example, we were talking yesterday about a whole system obesity budget, but what do you put in it and from where? In terms of local council, we were looking at their leisure budget to go in the obesity budget, so their leisure budget and their parks budget. But of course, these budgets do far more than potentially reduce obesity. And we've got the same problems with the health budget, so we can identify specific obesity things that, you know, pots of money that we spend on weight loss and bariatric surgery and those sorts of things, and the prevention agenda. But actually, some of the budget will be in our hip replacement budget, or it'll be in our budget for knee replacements. So actually, it is really complex trying to look at a place-based budget and then split it down even further. This slide really was just to give an example of the integration opportunity. You can see there the amount of money that we're spending on placements and residential and nursing care, and the small amount of money in relation to that we're spending on community nursing and intermediate care and the loan store, so equipment. I think it just shows us the opportunity of where we need to move money from and to actually improve integrated services. I think Julie mentioned earlier that in Kent we're a year of care early implementer. we focused on developing a linked data set, so a whole system linked data set. That gives us data on costs of care and where that care was taking place. It allows us to follow a patient pathway and see where the patient is spending their time and in turn where the money is being spent. It allows us to identify opportunities for commissioning and redesign. We're moving forward with next steps, which is to develop an integrated payment mechanism and capitated payment model that we are hoping to shadow test this year. And alongside this work, we're developing an integrated contracting model. We've got a Kent-wide work plan that will get us ready to go live in 17-18, but again, there's a lot of work to be done. And we also need to do some significant work on our database, in the next few months. So we need to review implications of shortfalls of data. So we've been collecting primary care data from practices, but we haven't got all practices signed up to put their data into the data set. So we need to understand what the implications are for the shortfalls in data for this. You know, does it affect the outcomes from the data set that we're hoping to use it for? So we need to also improve the data quality that is going into that data set. But we've got 7 organisations flowing data into our linked data set. So we will be using this to develop our integrated payment mechanism and capitated payment model this year. I mentioned contracting there, and the contracting needs to develop at the same time as the integrated payment mechanism. We know that we have a challenge at the moment with our procurement and with contracting. We have multiple providers that contribute to the outcomes for the patient. Most of the funding is tied up in acute and long-term social care. We've got community health providers where we are on block contracts and social care providers on time and task contracts. We've got inefficient workforce utilisation, and PBR doesn't incentivise reduction in admissions or social care changes, so we've got adverse incentives in the system. The University of Kent are working with us on developing a new contracting model. We've been doing this work for probably 18 months, 2 years actually. What they did was that they carried out a review of all current contracting mechanisms, so Alliance, lead provider, the Alzira model, etc., highlighting the positives and negatives of these. We then decided to use the learning from these models and design a new whole system model that would centre a new whole system model. And we wanted that new system model to be focused on integrated care. We wanted it to foster collaboration. It had to be based on achievable joint outcomes, system focused, as I said, and based on evidence and effectiveness. So we held a number of stakeholder workshops and agreed the overarching principles of the contract, and you can see these on the slide in front of you. But now the Vanguard are leading on integrated whole system payment mechanisms, and the Vanguard site is in Canterbury, and we're working very closely with them. So with the Vanguard leading on the integrated whole system payment mechanisms along with us, and I actually chair that forum, we are going to develop the contracting model alongside this, building on the work that we've already done. We're planning on testing the Alliance model along with a capitated whole system payment mechanism in South Kent Coast against our integrated enablement and ICT service, along with the use of the evaluation framework, which I'll talk about in a minute. And I think this will help inform the contract mechanism, as we will have defined the outcomes for the service, and these can be measured and added to the contract so that the contract is outcome based. So we are working on developing that new model. In Kent, we already use an Alliance contracting model with our LD programme of care, so we can learn from that. So this year we will be piloting the use of an alliance type contract with some of our services. I mentioned earlier that research and evaluation absolutely underpins all the work that we're doing in South Kent Coast, and we're working with the University of Kent to design an evaluation framework. In fact, we've designed the evaluation framework for integrated care. We don't want a report at the end of, the 3 years that says, well, that didn't work. What we wanted was a process that informed us at the time whether the changes that we're actually making were making any difference. And we want something that informs implementation and evaluation. So the university is using the evidence integration triangle that you can see on the slide here. And this research design recognises the difficulties in demonstrating cause and effect. And it promotes a more organic method, and it's able to determine what works for who and in what circumstances, with what effects and with what resources. So I think this approach will enable us to see what is working and what isn't, so that successes can be built upon and failures rectified as we begin to change the model of care. Alongside this, we will be using our Year of Care database to assess the impact of different interventions. So, for example, we can start looking at those people who go through the 8 to 8 primary care service. We'd be able to measure the impact on service use, and we would be able to measure the impact on costs by using our Year of Care database. Challenges and next steps, and I think you'll recognise some of these challenges. Capacity to do this work and to deliver this work is pretty critical. People are really busy. Organisations are quite small, particularly CCGs. So having the capacity and the GPs as well to deliver this work is quite challenging. Workforce is a challenge, as I said before. We're surrounded by C on 3 sides. We do have a workforce, we are developing a local workforce plan now. It will be ready in March. We've done quite a lot of work looking at what our future workforce should look like, different roles, blended roles, and we've looked at how we can attract people into the locality. We're trying to build a sense of belonging to South Kent Coast through the people that are already working within the system, because we do need to retain those people that are already here. Another challenge is the system complexity, which I've already touched upon at the beginning. We can't get rid of that. That's not going to change, but we have to work our way through it. Leadership is critical to this work. Again, it's a bit of a challenge, finding, particularly in the localities, the GP leadership. How do we create that momentum locally to move this work forward and that leadership? We are currently putting in place a leadership model in the localities so that we can begin to develop leadership in all of the localities, but a collective leadership model. Culture, I think, is really tricky. It's really difficult to change the way that people have always behaved, and I think it was Barking, Redbridge, Havering were talking to me the other day, and they said that the biggest thing to overcome for them has been the culture aspect. New contracting and payments, which I've just mentioned, which we will develop this year, it is a challenge because it is different. And the time frame for delivery, which seems to get shorter all the time. These are our next steps in 17-18, if we're expecting to have an embryonic ICO established with 4 neighbourhoods in South Kent Coast. These are our next steps for 16-17, particularly strategic next steps, particularly focusing on devolution. What does that mean? Making integration real, the social care transformation. As I said earlier on, they're ready to move really fast now in terms of the integrated commissioning aspect of older people's services. We need to explore the organisation models. We think we've got the function of the organisation. We need to explore more what the organisation model will look like that is wrapped around that model of delivery. And I think that's it.
Thank you, Alison. That was really useful and informative. We'll take questions in a moment, but can I just ask you about the contracting and the challenges that you're facing with looking at different types of contracts, and what sort of the reaction been from the acute providers that you've said, you know, there is a large proportion of the commissioning spend spent with the acute providers. Do you think they're fully at the table?
I think that's a really good question. I think it's taken quite a long time. I think what we have to keep doing is providing evidence that actually shows this. Our hospitals are bulging at the seams, and I would say that our acute trust would say, please take these people and please, you know, give them a better care out in the community. So I think they are absolutely on board with the model. I think what they would like to see is that this actually does impact on the activity that is happening in the acute trust, and I think that's, you know, quite difficult. So they need to be able to see that there is an impact and that they are able to close beds or, you know, have a reduction in the A&E admissions. They need to be able to see that. But we are in negotiation, and we're in the contract rounds at the moment, negotiation rounds. We are all signed up to this agenda, and in their contracts we have currently put that this is the model of care that we are hoping to deliver.
Thanks, Alison. That's really useful. Have we got any questions? I note, I don't want to put you on the spot, but Katarzyna from West Hampshire, I know, I don't know if you've got any questions, because you've listened to what Alison had to say, and I don't know what work, well, I do know lots of work is going on in West Hampshire because you're also a year of care commissioning site, but was there anything that you would like to ask Alison while you've got her attention?
No, I think I'm new to the organization and quite new to the commissioning world, so it was very interesting, but I don't think I've got any questions.
Okay, thank you very much. Lynette or Susie, have you got anything that you'd like to ask Alison while you've got her?
No, I haven't. I thought it was very interesting, though, and I think it does just show the complexity of what you're trying to do. So I'm very impressed with how you're working it, and also I think it's really important that some of the sites that we're working with, as you know, CCG sites that are not working on year of care yet, and how you've integrated the two things. So very interesting. Thank you.
Fantastic.
Thank you. I'm quite. Sorry, Jude, I was just going to say I'm quite happy for people to contact me afterwards if they've got my details,
yeah.
And I'm quite happy to have, you know, conversations at a later date if something comes to people.
Brilliant. Thanks ever so much.
Julie, sorry, Jamie just got his hand up.
Yeah.
Jamie, have you got a question?
Yeah. I think I heard, Alison, that you're using an alliance contract, but you've got your local health and wellbeing board will hold the budget. Just interested how that might work. So who's the contract between? Is the health and wellbeing board acting as a commissioner at the centre of the alliance contract, or how's that working?
I think that's a good question, Jamie, and remember that we're at the beginning of this year and developing it as we go along. So the Health and Wellbeing Board isn't in the position yet to be able to hold any contracts. And as we move forward, we'll have to think about what that might look like and who holds the contracts. At the moment, it will be the statutory organisations that hold that alliance contract. So it will be well, the CCG and KCC, what we're looking at is merging the budget for a specific service that is currently provided by almost five different providers. Yeah. The budget that pays for it currently sits in KCC Older People's budget and in the CCG's budget. So we need to agree how we're going. We've got agreement to take this forward, so everybody's happy with taking this forward, because we're going to use it as a bit of a pilot, I suppose, really, for that alliance approach, and you know, for merging the budget.
Yeah.
So the holder will either be the CCG or KCC at this moment of that contract, because the Health and Wellbeing Board isn't developed nowhere near enough to be able to hold that. What it'll look like in the future, Jamie, I don't know. We've got all that to work through this year, and I think it's going to be pretty challenging.
Yeah, yeah. No, that's fine. I agree.
Thanks, Alison. I think Bev's got a couple of questions, Bev, for Alison.
Yeah. Just adding on to, I didn't think health and wellbeing boards would ever hold contracts. I thought they were an advisory governance type thing. So that's interesting to see a way you see it happening, but we'll see.
We'll see. I think it's all in development, Bev, and that's the thing, isn't it? And as it stands at the moment, the way that things stand at the moment, there's no way that the Health and Wellbeing Board could hold the contract. The law would have to change. So, you know.
And their maturity and all of those sorts of things, you know, for something to actually be sustainable and safe, really.
Absolutely.
And BHR is underwritten for 2 years by the CCG because of the amount of money, you know, that's involved. It's a huge risk,
It is. And I think that comment that you made there, the maturity of the Health and Wellbeing Board, we're right at the beginning of this journey, and they certainly are not in a position to be able to do that this year. So what we've said in South Kent Coast is, let's take a couple of examples. So we're using frail elderly and we're using obesity, and begin to work some of this out over the next year and see what it could look like. See and put a development programme in to underpin that for the Health and Wellbeing Board. We're also, I mean, and bear in mind, this is a local Health and Wellbeing Board. It's not our Kent Health and Wellbeing Board. It's the local Health and Wellbeing Board. So there's a lot of development there to do. But we've started the process, and we're starting the journey, I suppose.
And it's brilliant to see, because one of the observations always made about Kent, you know, was that you were all about the data, which you are, and you should be. But it's really nice to see it now moving on from that and applying. And what would be really interesting is, unfortunate, you know, this is the last year, but what would be really interesting is to see in a year's time those that perhaps weren't all about the data, how far they actually get with their plans, but how quickly you will now move, because you've got robust data behind you that you can look at in almost real time.
Real time,
which is really good and really strong. So well done, you. My other question was really just to see, and kind of an offer, if you like, for maybe Susie or Lynette to come and support you with, but just around the behavioural change element. Is there any work we could do to support you with any of that, with the tools that we've got?
Well, I think that's a great offer, Bev. I would be happy to talk with anybody about that and look at how we could be supported, because it is a challenge, and I'd be grateful for any help at all with some behavioural change. Yeah, that'd be great.
Okay. I mean, they both work together really well on running our staff-facilitated workshops, which just gets everybody into the room and onto the same page, you know, that sort of thing. So, we'll maybe leave. Julie, can you link Susie up in the first instance? But
that'd be fantastic.
Through them, and it's a fabulous amount of work, and we really need to help make sure that we share this more widely. Really, because just done so much. Well done. Seriously, well done from me. Well,
I'm happy to talk to other groups if you want me to. That's not a problem. I can cut it down as well. So I can make it shorter, but I wanted to get it all in.
I know, but you tell it as a good story, which is captivating. So well done. Seriously, well done.
Thank you.
Well done. So I'll hand you back to Julie now. Thank you.
Thanks, Alison. Just want to close to say a big thank you again, Alison. And if you wanted the final word in terms of what other people should be looking at.
Well, I was thinking about this, and interestingly, I'm just in the process of doing my gateway review on this programme, because I run this programme and I also run a similar programme in SANIT, so two big major change programmes. And I'm doing this programme review, and I'm about to speak to our executive board next week, and I'm going to start with a slide that shows the Millau Bridge. Now, I don't know if people know the Millau Bridge, but it's the tallest bridge in the world. It's a viaduct bridge between Paris on the autoroute between Paris and Béziers, and it's a 400 million euro to construct. Now, and it's the longest cable-stayed bridge in the world. And it took 10 years to plan, and it took 3 years to build. And why I want to say about that is that don't move too quickly into implementing. Planning is really important. And with this bridge, the 10 years that they planned, they did 3 years to build. It is very complex, is the bridge. But they had very few problems in their implementation, so in their build of this bridge. And so what I want to say is, you know, I know we're all trying to run as fast as we can to deliver this, but planning is really important, otherwise we'll end up with something that we don't actually want and that doesn't work.
I agree with that, and when you chat with Susie about the behavioural change work, have a chat with her about the Kirkpatrick model that we're using to look at evaluating and measuring the programme, and I think that resonates. I don't know if Susie could come off mute, but I think that resonates really, really well with that example of the bridge.
Yeah.
I think it fits perfectly, but have a chat when you get to speak. I think you'll find a lot in common there.
Great, thank you.
That's brilliant. And just to say thanks again, and thanks everybody, and we'll call the webinar to a close. Thank you.
Thank you.
Well done.